Good afternoon, everyone. We're very happy to host you here at ESICM for this wonderful, lively talk that we're going to be having today. My name is Julie Ben-Benishti. I have my PhD in critical care. I'm a nurse from Israel, and I'm co-chairing this session with Susanna Lever.
Hello, my name's Susanna. Welcome to this webinar. I'm a consultant intensivist at St George's Hospital in London.
My name Today our discussion, where we'll introduce our speakers shortly, but the topic of our discussion today is going to be Dr. Rui Moreno will be talking about the nuts and bolts of SOFA scores, and Dr. Shahala Siddiqui will be talking about making decisions with numbers or using gut feelings. So I am predicting this is going to be a very lively discussion. You, as our audience, will be able to ask questions of the speakers through the chat. The chat will be, we will receive me and Susanna will receive your chat questions, and we will ask the speakers those questions at the end of their presentations. So first, I'd like to present Dr. Rui Moreno. Rui has received his medical physician first in internal medicine, and then immediately after that went into critical care, and has been a leader in critical care for the past 30 years. Rui was past president of the European Society of Intensive Care Medicine and was awarded the gold medal from the European Society in 2016 for his exemplary contribution and commitment to the cause of intensive care medicine in the world. Rui is an outstanding leader, an outstanding researcher and educator. And now we'd like to hear from Rui Moreno.
Thank you, Julie. Thank you, Vaidis. I will try to speak in the next 20 minutes about the nuts and bolts of SOFA scores. And first of all, my disclosure. I see everything because I have some deformation from the eyes of an intensivist. Because I started to perform intensive care almost as soon as I graduated, 2 years later on or something like that. And I dedicated half of my career to the problem of establishing or trying to find a prognosis and to foresee what is going to happen to our patients. And okay, we had many ways to do that, some more basic, like this one, some really sophisticated, that not even with a PhD in maths, you can understand fully what you are doing, but that's evolution, and it's a good thing in my view. And over the last years, since maybe 74, that marks the first outcome prediction model widely used in intensive care, we created a lot of scores, triage scores, admission scores, multiple organ dysfunction scores, that is what we are speaking today, discharge scores and nursing workload scores, and MET scores, after and also before ICU triage. And if we want to summarize or to split in 3 parts, and because I think it's easier to explain, the first thing we created scores, and to use scores was to predict what was going to happen. What is used not only in medicine, if you go to Wall Street or London trade marketing, you are using models to do that and to see where you should put or not to put your money. And in medicine too, we have the general severity scores to gen outcome prediction models, things like Apache, like SAPS, like NPM, and many, many, many more that assign a certain number of points to a patient based on the physiologic derangement and other variables. And then some of them, the outcome prediction models, use that information to predict a given outcome. And when you look at the last ones that were published, half of the prognosis of a patient from the mathematical point of view is set when the patient enters the ICU, is predisposition, age, frailty, diagnosis, chronic diseases, and all that stuff. So on that half, we cannot do a lot in the ICU. I cannot put my patients younger, more fit, with less sarcopenia, with a better mind. I can, in some point, to modify the circumstances of ICU admission, diagnosis, physiologic status at admission, where is the patient coming from, and how much time did the patients need to reach ICU. And we are intervening a lot on this, making this track faster and faster. And then we have 27.4, that can be up to 35.2%, that is acute physiology, tachycardia, hypoxemia, bradycardia, oliguria, things like that. And in fact, if you think in a multiple organ dysfunction score, this is what we are tracking daily, sequentially, not just at admission or in the first 24 hours, like SAPS-3 or SAPS-2 or Apache 3, 4, 2, 1. But we are tracking at this on a daily basis and not once to see into global or organ by organ what's going on the patient. And it's our duty to do so. I'm not saying this from my own head. I am just quoting William Hosler, that was saying that, well, more than 100 years ago. And so the first question is, can we use these organ dysfunction scores to predict? I would say it does not make a lot of sense. And that was the reason when these people, just one is missing, because I could not get the picture, that is Arnaldo Mendonça from Brazil, that we decided to publish a score in 96, that was done 2 years before, so in 94, to describe and not to predict. And this was the original table. It's very, very outdated nowadays. But what we wanted to do was to evaluate mortality and not risk of death. We want to describe, not to predict. We want an easy instrument that you should be able, with a pen and a pencil and a piece of paper, eventually, if your mind is not enough, at bedside, and not with a supercomputer somewhere on the back of the hospital. And that was able to individualize the degree of dysfunction of each organ daily. When I say daily, it can be any other periods. The crucial word here is sequentially. It could be every single day, every 12 hours, every 48 hours. There are very few studies who try to compare these different time periods. And did they not find, unless you go over 24 hours, a great improvement in this stuff. So we try to choose the ideal variables for this, and when Jean-Roger Legal and Stanley Lema showed, because we did not even have a database at that time. So they were so kind that they gave us or allowed us to use the database where MPM2 and SAPS2 have been made, just to look at the relationship between our 6 organ systems and mortality. And in fact, it seems to work. ICU mortality, not hospital mortality like general severity scores. And it seems to work quite well. And so only 2 years later, and it was published in 1999, we were able to do a multi-center and proper validation of the SOFA score. And in fact, it worked quite well. We should note that at that time, and this is 90s, predisposition had not a so important role as today, because our capability to correct physiological dysfunction was much lower than today. And this, for me, is one of the proof that we are evolving as a specialty a lot. When Knaus published Apache 3 in 91, almost 43% of the prognosis of a patient was due to physiologic dysfunction, the range physiologic dysfunction. Now we are speaking about 27, 30. So we learned a lot how to deal with the range dysfunction. Jean-Louis did the same with Flavio, and he found that even better than SOFA score and admission was delta SOFA score, that they define it at the difference between admission and 96 hours. Other people used a different time frame. For example, in my work, in my paper, I use 72 hours. Does not make a big difference. It's always better to track things over time, that's the message, than to track it on admission. No matter if you call it overtime, 72 hours, 96 hours. And in fact, you have a very nice work from Lillian Min that was published not long ago, in 2008. Well, already a couple of years, but not so long ago, as SOFA, looking at all the attempts to predict mortality. I will not go in detail on this. They even try to combine SOFA score with classical severity scores to see if it worked better. But in fact, no. When we look at our data, you can see in red non-survivors, in green survivors. SOFA score goes from 0 to 24 points. You could see a very nice relationship between the two issues. So in some aspects, they were able in the 90s to see if everything will be fine with the patient or no. But we did not SOFA score for that. We did it to describe what was going with the patient. And the patient has many organ failures, or can have many organ failures. More than 6 we choose, or we were able to track at that time. But we focus on the evolution, on the sequential evaluation, on time, important of time. And so if we want to do that, we have to use a common terminology, which variables, how we define the variables, at what is the timing to apply the SOFA score because there are several ways to compute the SOFA score: admission, maximum, maximum daily, delta, mean. There are many more. And so we decided that it was needed, and other people, to describe this in detail. So our language will be the same. Because look at these two pictures. They seem similar, but there are thousands of hundreds of millions of dollars or euros between the two, the original and the fake copy. And the same is true for SOFA score. Each time you change one line on the definitions, you are changing the score. It's the same if you take the general relativity equations from Einstein and you replace a minus by a plus. You can have a great equation, but it will not be Einstein equation that until now had worked more or less in most things. So we have to define it, these on the beginning, and not just to toss a coin and see the problems, how we should define the variables. And from this came, for me, the biggest nuts and bolts of the SOFA score. Which variables, how I define it, how is the timing for application, and if I am associating another thing. Because in some, not in all, but in some, I will just give 2 or 3 examples because of time, on scope of time. Thinking cardiovascular system, this is the original SOFA score. But nowadays, at least in my country, in my setting, we are not using anymore only these vasoactive drugs. We are using another ones, and we are using another doses. And if I change one point on this, I will be building another score, but not SOFA score. So we need to take this into account. Another issue on cardiovascular components is the increased use of extracorporeal assist devices, like VA ECMO. You have new drugs, you have new management strategies. And the same is true for other things. Think of respiratory component, where is high-frequency oxygen. We did not have it in 96. Where is VV ECMO? Where is even prone? So we don't know if this reflects our practice. And I cannot change this, because if I change this, I am not using SOFA score anymore. And if you look at PF ratio of this lady, and I ask permission to use this picture, the PF ratio of this lady on ECMO was greater than 400. She would have a SOFA score maximum, if I consider ECMO type of ventilatory support, should have a maximum of 3. And in fact, she is on top of support I can nowadays give her. And she is wake up. She is with a nice PF ratio. Same is true for Glasgow Coma score for evaluation of neurological status. Well, the relationship is quite nice. But most of our patients are sedated, more or less. We are sedated patients less and less. That I agree, but still a very severe patient in most cases will be sedated. Or it can have a TBI or another brain condition, or could have dementia. That is no more than a chronic dysfunction of the central nervous system. And finally, we have been criticized in these 25 years because we just evaluated 6 organ systems. And possibly there are more than are important. And we were not able to do that. So we have to be very strict, understanding that multiple organ dysfunction syndrome is a process, is not an event. So we have to track it over time. We have to think and to realize that always that things change over time, especially in severe infection. And in fact, it's not just the amount of dysfunction that is important, it's the duration of that dysfunction. Because I did not put slide here, but we know that if your SOFA score in any organ does not begin to decrease after 48 hours, your mortality is going up, even if the score is flat, because that means that you are not intervening or that your intervention is not useful to decrease the dysfunction of that organ. So these are the main differences between description and prediction. And this is not new. René Chang was a surgeon specialized from London, in Saudi Arabia, specialized in kidney transplantation, have done that in the late 80s with not a big success, using a combination of OSF plus Apache 2. It was not a big issue. So we want us to focus just on this. Describe from ICU admission to ICU discharge, and to track the evolution of the patient over time on the overall or organ by organ. And you can see that for some organs, things are improving. Maybe I am using the right strategy. And for other organs, maybe I am using the wrong strategy. Can I use this to triage patients? And we discussed that a lot, not on COVID. This discussion started with H1N1 in 2008, 2009. And at that time, nobody knew exactly if we could use this for triaging patients. But, well, was better than a random method. And this table was proposed to the European Commission at that time to admit patients to the ICU in case of severe H1N1 flu. Not so different compared with some discussions I heard not so long ago about COVID. And this has been proposed also for COVID. Okay, the slide, the picture is more fancy, is more modern, but the message is the same. They can, within some limitations, be used for that. But we know when I triage a patient, I am done, no matter my decision. If I am using a mathematical model without the agreement of the society and the agreement of the family, because the patient many times is not in conditions to help us to decide on his future. So to conclude, maths are almost as complex as life. And we need to have really hard data to do this. Because there are other important things that I already spoke, the role of the physiologic reserve of the patient, organ-to-organ interactions, not all organ failures have the same degree of reversibility. Which is the best SOFA? Admission, maximum daily, cumulative maximum, delta, all of them? I would say all of them. They can be used for different things. Chronic organ dysfunctions. For me, we have to evolve on this and to understand better this, because we know that these maths are really complex, but we are evolving and we are changing our practice. My ICU 20 years ago was like this. Now it's more like this. ECMO, easier to stay. Half of these devices did not existed when I graduated. So why should I continue to use the same table we developed in a very interesting meeting in Versailles in 94 and finally published in 96? So that was the reason why we challenged in January this year the scientific community that was time to an update. And because we are using different strategies and different variables. Do we have to care with chronic burden of disease? I don't think so. The difference when I track patients every single day is that, this young patient with no prior disease, just, a motorbike accident on day 1 or day 0, does not have a huge chronic burden of disease. These old men with 70 already entered ICU with a large burden of disease. But the red one is the part where I can act. I don't know yet how to reverse Alzheimer. I don't know yet how to reverse chronic, subtypes of chronic heart or respiratory failure or terminal kidney disease, apart from transplantation. So I don't want to care with that. I want to describe this because this is the point I am able to modify. And possibly nowadays, I hope that we are able to add immune system and gastrointestinal system at least to SOFA score, and not to focus only in North America. Nothing against North America, but you have to think in South America, you have to think in Europe and Africa, and many of the problems and of the severe dysfunction, especially in young people, are in the other side of the globe. So we want a more global score than was SOFA. SOFA was made for Europe, Canada, and United States. That was what was in our mind in 94. And I don't think this is acceptable anymore. So we want to do something that can be used as easily in London or in Bangladesh. Maybe artificial intelligence will help us, but I would say it's too early to rely in ChatGPT and ask ChatGPT, shall I go to the ICU? Yes or no? I would say it's too early, maybe in a few years. And that will be our future if ChatGPT really works. Because then instead of doing severity scores or prognostic scores and dealing with sick patients, someone on the ICU will ask the ChatGPT for the best therapy, the best management strategy. So not to make the same mistake of changing the score and not changing the name. That is the reason why that group of intensivists proposed to build SOFA 2.0. And we put together 58, I think, at the moment, intensivist methodologists, statisticians, people with experience of practicing ICM in countries with low or middle income rents, and then to validate it everywhere. And we are working on this. You will ask me, and I am already out of time, and I apologize for that. When will this will be ready? I don't know. I hope by the end of the year we will have something ready to be tested, not ready to be used, because this is ongoing. And I think that we will be able to describe better what is going on with our patients, and then to be able to use that for decision making. Or we may fail. Failure should never be an option, but may happen. And in that case, we'll do not add progress anything. So we will continue to use SOFA 1 or tossing a coin. But to finish with the question they put to me, the nuts and bolts of SOFA scores, read the fine print. Don't try to modify anything. I have in my computer, and I was counting a couple of days ago, 183 modified cardiovascular SOFA scores. Only one is original. All the other ones should be SOFA 2, SOFA 3, SOFA 183. And possibly I missed some. So it should be, the number should be greater than this. And my last word, if you really want to change SOFA score, change the name. Do another score. Call it another name. And that was the reason why we proposed it to do SOFA 2.0 instead of just updating SOFA. Thank you very much.
Thank you, Rui, for a fantastic talk. If anyone has questions for Rui, we're going to have the questions at the end, so please put them in the chat. And I'm delighted to announce our next speaker, Dr. Sharla Siddiqui, who is an anaesthetist, intensivist, and ethicist at the Beth Israel Deaconess Medical Center in Boston. She's an assistant professor at Harvard Medical School, and she has a number of research interests with a particular focus on social sciences and humanities work in intensive care. And she's going to talk to us about making decisions with numbers or gut feeling. Thank you, Shayla.
Thank you so much, Susanna. Thank you, Essican, for having me. And I'm really delighted to be here talking about such an important topic and something that's close to my heart. Not really the SOFA score, but really how we integrate human beings and patients who are actually like us coming to the ICU and their families. So as Susanna mentioned, I've been practicing for 22 years in the ICU. And due to certain encounters in the ICU and my personal life, my parents being in the ICU, I took an interest in ethics and also in how human beings are dealt with or how we deal with each other in the ICU. So my research mostly is in humanities and medical ethics and social sciences. My ethics theory and my thesis for my master's was on how patients view the dilemmas of elderly critical care. And the thing that came out mostly with the 72 focus group discussions was prognostication. So the real bone of contention for triaging patients for admission, and I certainly hope we don't move forward with ChatGPT deciding about who's coming to the ICU. I'm sure Dr. Moreno was being facetious, but I'm seriously concerned now But I feel that my thesis showed me that it's really prognostication, the prognosis, which brings about the most dilemmas and the most conflicts within ICUs and within misunderstanding or the expectations of what we can deliver in the ICU. So with that, I'd like to talk more about how do we make decisions, and do we make it with numbers or gut feeling? This was a topic given to me, and I'm going to try and show that it's a combination, but having a clinical acumen and a more compassionate attitude is generally the better way to go about it. I have no disclosures relevant to this talk. The outline of my talk includes the relevance of the SOFA score in the ICU, arguments for and against the use of scores in general in outcome prediction, physician perspectives and ethical dilemma, patient and family impact, the role of intuition or gut feelings in critical care medicine, and then the conclusion. So the SOFA score was designed initially as a research tool so that groups of patients, example those with sepsis and infection in the bloodstream, which can lead to shock and death, could be categorized based on their risk of death. SOFA is quite accurate when used in sepsis cases and when applied to groups of patients. And the sequential organ failure assessment, or SOFA score, is a mortality prediction score that is based on the degree of dysfunction of 6 organ systems. It's calculated on admission and every 24 hours until discharge using the worst parameters measured during the prior 24 hours. The scores can be used in a number of ways as individual scores for each organ to determine progression of organ dysfunction. So you can sort of go along the trajectory of the patient and see how each organ function is doing, or as a sum of scores on a single ICU day as the sum of the worst scores during the ICU stay as well. It is believed to provide a better stratification of the mortality risk in ICU patients, given that the data used to calculate the score is not restricted to just the admission values. But in literature, I found tips from the creator of the SOFA score, Prof. Jean-Louis Vincennes, whom I know very well. The respiratory dysfunction component is often misunderstood, he says. The patient needs to have some respiratory support, mechanical ventilation or non-invasive, to have a respiratory score of 3 or 4, to make sure it is not just some minor atelectasis, but not the other way around. So a patient can have a good score, but they may be on a lot of support, as in ECMO patients, as Dr. Moreno mentioned. A comatose patient may need mechanical ventilation and yet not have significant hypoxemia, but they're really sick. It is also important to realize that the neurologic score in sedated anesthetized patients corresponds with the GCS that the patient would have in the absence of medications, that is the assumed GCS. So again, there are some fine nuances of how we use the SOFA score and how it is scored individually. Now, arguments for and against the use of scores in outcome prediction. This was a paper in Critical Care Medicine in 2018. SOFA was developed to be used with populations, and though it is good at determining overall mortality, the score cannot predict individual mortality very well. So at the bedside, when you are using it for your individual patient, it's hard to use a score when you have a real-life human being present in front of you with their families, and you're going to talk about population SOFA scores or population outcome scores to that family. They will not understand anything. They are going by what their hopes and dreams and expectations are. And you are going as a clinician on how the patient has responded to your therapy. Clinicians should not use the SOFA score, the authors of this paper say, in isolation to exclude a patient from receiving interventions. Given current unequal patterns in social determinants of health, as we saw during COVID, U.S. crisis standards of care utilizing the SOFA score to allocate medical resources would be more likely to deny these resources to, for example, Black patients. And we saw that. I was part of the Harvard Crisis Standards of Care Society that was determining triage when our resources were were terribly scarce. And we were horrified that we would be denying mostly patients of underrepresented minorities if we went on these scores. In this cohort of patients with COVID-19, age was a better predictor of outcome than was SOFA score. Although SOFA score is attractive as an objective way to triage patients, it does not perform well for critically ill patients with COVID, and we should consider its role in decision-making for these patients. And I would like to put forward that it's not just during COVID, but also on an individual level of severely ill patients. It may be easier to look at the overall picture of the patient and their response to therapy when I'm called to the ICU, to the ED, for example, to take a patient. I'm not there with a calculator trying to find the SOFA score or any score for that patient. I am there looking at how the background of the patient is, what previous history is the patient. And if I have scarce resources, I'm going to be talking to the family. I'm going to be talking to the patient and going to look at how well the patient has responded so far and how the lactate is coming down, for example. What is the mechanism of their illness or the etiology of disease? Now we look at physician perspectives and ethical dilemmas. So again, another study that I am doing in the ICU is on moral distress. And believe me, if you're using objective and mathematical models for futility, for determining futility, we don't use that word anymore, but really for non-beneficial care, it causes the most moral distress among nurses and doctors. Prognostic scoring that is relevant to settings without extensive laboratory capacity is needed so that resource use decisions can be based on the best data available. It is ethically appropriate and even mandated to use the best data available to us. That's why we do daily tests in the ICU. But what about places and countries that don't have the laboratory facilities available or finances? I come from Pakistan originally, and I know that families often have to pay for each test that you order in the ICU for these patients, for each therapy, for each medicine that you give them. So it becomes very difficult to use, like Dr. Marino mentioned, in different parts of the world, these scores for prediction. Probabilities of hospital mortality provide meaningful information in many contexts, such as in discussions of patient prognosis by intensive care physicians, in patient stratification for analysis of clinical trial data by researchers, and in hospital reimbursement analysis by insurers, which is a big thing in America, unfortunately. Again, in database studies, when you're looking at SOFA scores, context is very important, which is why retrospective database studies are often not very valid when you look at them qualitatively. So we did a study looking at racial disparities in a retrospective database before and during COVID. And we saw their SOFA scores, and we found that patients who were Black, for instance, were made DNR earlier. Now, we have to go forward and do a qualitative study and see whether this was really goal concordant or not. So there are many nuances of using scoring systems, even in retrospective database studies, and the basic context that you use to come to conclusions. Now, the use of probabilities as binary predictors based on a cut point can be misleading for making treatment decisions for individual patients, especially if you're using a number and you're going to go by that number. However, even when model performance is good overall, alternative models for estimating severity of illness in ICU patients, while demonstrating good agreement for describing patients in the aggregate, are shown to differ considerably for individual patients. So, with the same severity of illness, people can score differently. And are we going to hold back or triage patients based on that, hold back treatment, for instance? ECMO has now become a big decision maker in our ICU. And when we have teams deciding on ECMO, it becomes very difficult to only use scores, because here you have young patients, especially for VV ECMO or for a fresh cardiac arrest, you have just 5 minutes to decide whether you want to put them on a VA circuit or not. It becomes very difficult if you're just using a number. This suggests that identifying patients unlikely to benefit from ICU care by using models must be approached with considerable caution. And this is again from a study that was published. Let's talk about the patient and family impact. As I mentioned, my thesis was on ethical dilemma in ICU with elderly critical care, and prognostication became the biggest bone of contention and the biggest cause of moral distress among families. The systematic differences in calibration across ethnicities suggest that illness severity scores reflect statistical bias in their predictions of mortality. And this has been proven again and again. Black patients don't score well, especially when you're using the pulse oximeter or you're using other predictors. They come in with renal disease. They will score higher, but are we going to withhold treatment or withhold triage for them? This has become a big question in the US. Despite the existence of many prognostic models and their attractive potential utility, scoring systems have a limited clinical value at the bedside and are seldom used in practice. Now let's talk about the other side of this title of my talk, the role of intuition or gut feeling in critical care medicine. One doesn't, in this sophisticated age, only use gut feeling, but one does use intuition and one does use experience. And there's a lot that can be said for clinical judgment, and it remains a fundamental point of discussion and decision-making, which is why we have attendings and consultants in the ICU leading rounds, and not just, junior residents or junior faculty, or I wouldn't say faculty, but residents or trainees with a calculator. Because you have experience here, you have clinical judgment, you have acumen, and yes, you have intuition, because not all relevant variables are included in these models. They're not contextual, they're not compassionate. Scoring systems provide only probabilities, not certainties. It would be inappropriate to deny or withdraw care based solely on a probability derived from any existing scoring system. The course of illness over time is important, so the trajectory is important. How patients respond to treatment is important. So in conclusion, clinical variables may not be included in these models, and clinical judgment and ethical principles need to be employed when making decisions regarding prognosis in an individual patient. For a family member to hear that 20% mortality from previous studies and scores is what 20% survival is what we see, and therefore your mother or father or sister or husband will not do well because they have an 80% chance of dying. For that loved one, even that 20% is enough to go on. So how do you base your decisions on just numbers and percentages? For example, the physiologic response of sepsis, which is linked to unknown genomic factors, is not taken into account of the scoring system. Human physiology is complex, and clinical assessment prevails over scoring system predictions. And in the end, I would like to leave you with this saying from Plato, famous philosopher: a good decision is based on knowledge and not on numbers. And this is way before ChatGPT came along. And I still think that this should be the baseline and the backbone of how we practice medicine in general, and especially in the ICU where life and death decisions are being made. So with that, I'd like to end my talk. Thank you so much for this opportunity.
Thank you, Sharla, for a very interesting and fascinating talk. As I said earlier, if any questions, please put them in the chat. I've got one to start off with. The question from someone in the audience is, do you think that the use of markers like lactate or others should be considered together with SOFA, or even when SOFA score is not possible, to be immediately calculated?
If I may take this question, I use lactate all the time, not for triage decisions, but to see severity of illness and response to therapy. So it's part of the surviving sepsis 6-hour bundle and the 24-hour bundle. If you don't see a lactate coming down with your therapy, you need to do more. And if you see that lactate is extremely high on admission, that can tell you that this patient may not do so well. So lactate is very important, and it's really integral in all the septic shock treatment or the trauma treatment that we do. So lactate is very important.
Rui, have you got a comment on whether you would include it in SOFA 2.0?
You're on mute. Rui, you're on mute.
I apologize. I was. Lactate is, in fact, a very good example. It's not part of SOFA 1. Who knows if it will be part of SOFA 2? I don't have to answer yet. But it's a good example how we can combine our gut feeling with numbers. Because when I use lactate dynamics, not static value, but dynamics. If it's increasing, decreasing, if it's stable, I am putting a number to help my gut feeling about what is going with the patient. An high lactate or a lactate that does not goes down, does not tells me that I should stop therapy or that I should increase therapy. I have to put it together with other variables. Some I can quantify, some I cannot quantify, but is a warning sign that something is not on the right direction. And that for me is why we should use severity scores, sequential severity scores, or whatever you want to call them, to help my clinical evaluation. Not to replace my clinical evaluation, but to help my clinical evaluation. Because at the end of the day, what is my clinical evaluation? Is looking at the patient, seeing if its skin is wet or dry, looking at the blood pressure, looking at the heart rate, looking at the prior physiologic reserve of the patient, age, chronic diseases. So they should be complementary. We should not be fighting with gut feeling against severity scores or the other way around. We should make them work on the benefit of the patient. So, if it will make part of SOFA 2, I don't know. Ask me in 6 months, maybe.
Another question that's come up from the audience is, how about NEWS versus MUSE versus SOFA for renal replacement therapy decision?
Well, we use NEWS too in our hospital outside the ICU. We don't use inside the ICU. We don't use SOFA score outside the ICU, but just inside the ICU. So the comparison is quite difficult. But I say the decision to start a patient on renal replacement therapy depends on a lot of variables. Depends on why the patient needs kidney replacement therapy. That for me is the most important question, is why this patient needs that therapy. Do I have other methods to avoid renal replacement therapy? Fluids, for example, increasing the blood pressure, or I really need therapy. So I think neither NEWS or SOFA would tell me that the patient needs renal replacement therapy. It's a combination of several variables, some that are in scores, like oliguria, like creatinine, some that are not there, especially the diagnosis. Why this patient and physiopathology of the question. Why this patient would need renal replacement therapy. And last but not least, will this patient benefit anything from renal replacement therapy, or am just delaying the death of a patient that due to other organ failures or other conditions will die anyhow, no matter if he dies with 10 milligrams deciliter of creatinine or with 1. So
the question, now I'm clarifying the question. The RRT was not renal replacement therapy, it means rapid response. So, rapid response team, how would you use NEWS versus MUSE versus SOFA for a rapid response team decision?
We don't use SOFA at all for that. SOFA was developed to be used inside an ICU. And most awards, at least in my country, will not have the level of monitoring like blood pressure every single hour, amount of vasopressor drugs into ward, and many other values to be valid outside the ICU, unless you are doing a blood lactate or a PF ratio every single hour outside the ICU. So outside the ICU, we use NEWS to detect early on, to help nurses to detect early on when they should call the ICU or the doctor in charge of the patient. So for that, we use NEWS. You tell me it's perfect? No, not at all. But we don't use SOFA for that. SOFA was designed to have a sampling rate of the variables that is too high, at least for our medical surgical wards.
Okay, thank you, Rui. I think we have time for a quick response from you, Shala, and then we have to close the session.
Sure. I think Dr. Moreno is absolutely correct. It is very contextual. Many things need to go into the admission to ICU decision. There is quick SOFA, Q-SOFA, which has been proven to be very sensitive and specific, and it's just 3 variables, which includes a clinical variable as well, not just blood tests, so respiratory rate, etc. But it's really your gut feeling. You know when a patient is looking terrible on the floor and you give them an ICU bed and you say, well, I really think they need to come to the ICU. And you base it on data. So like Dr. Moreno said, it's an overall context with data, but not just a number on a score.
We have time for the last question that someone just put in, which is, do you think that risk scores that incorporate detailed alterations in physiology during the first few days on ICU might be able to give us more confident estimates of outcome, as opposed to simple measures just as a snapshot at admission? I think maybe you answered that in most of your talk.
Yes.
That has been proved for 30 years or more now. If I do sequential evaluation of what's going on, I would be better at the end than if I see the patient just once, no matter if I see it on my outpatient clinic, on ICU admission, or with a severity score. Because if I do it sequentially, every 24 hours, every 12 hours, every 48 hours, it's the same with clinical care. If you just see your patients on ICU admission, and then 2 weeks later on, the family asks you, well, how is my patient go? You don't know. You just know how was the patient 2 weeks ago. The same is true for severity scores. If I do something like Apache or NPM or SAPS, just on the first 24 hours, that can be used for a lot of things, but not to tell to the family or to the next of kin or whatever, how the patient is evolving, is getting better or no. For that, you need a sequential evaluation of the patient. And it does not matter if it's a clinical sequential evaluation, if it's a mixed clinical evaluation, if it's a sequential severity scores, but we need to keep your eyes on the patient and not just to trust to put all your coins on the bet at ICU admission. I did the right decision. I admit this patient, and I don't see the patient again. That will be a disaster. No matter if you are using clinical skills or if you are using severity scores. But if you want to use severity scores, do it sequentially. Don't do it at least to track the evolution of a single patient. Mm-hmm. Don't use it just on admission or at 24 hours.
Thank you so much. Thank you very much, Rui and Sharla, for 2 fantastic talks. And thank you to everyone for attending. I think we can finish saying that we definitely do need severity scores to track patients on the intensive care. However, we also need our clinical acumen as well. So we still got jobs.
Yeah.
Thank you all very much. Thank you, and have a lovely evening and afternoon. Bye-bye.
Good evening, everyone. Bye-bye. Thank you for attending.
Bye. Thank you.
Thank